week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
First, I'd like to introduce Dr. Ashley Franco from UChicago Medicine.
Okay, good afternoon, everyone. Hopefully you all can see my screen. My name is Ashley Franco, and I'm the current PGY2 Emergency Medicine Pharmacy Resident at UChicago Medicine. And I will be presenting my journal club today on front-loaded versus low-intermittent phenobarbital dosing for benzodiazepine-resistant severe alcohol withdrawal syndrome. So it's important to talk about the background of alcohol withdrawal syndrome. So first, alcohol continues to be one of the most frequently used and misused substances in the United States. In 2021, around 40% of all drug-related emergency department visits were alcohol-related. And individuals who binge drink, which is considered greater than 5 drinks or for males or 4 drinks for women in a 2-hour period, or heavy alcohol use, which is considered greater than 4 drinks for males in one day or 3 drinks for females in one day, are associated with the highest risk for developing alcohol use disorder. And alcohol use disorder is considered a neurologic disorder, and it's really characterized by the impaired ability to stop or control alcohol use despite socioeconomic consequences, whether that being unable to get out of bed or go to work in the morning. It's currently estimated around 14.5 million people in the US have alcohol use disorder. So then getting into the pathophysiology of alcohol withdrawal syndrome. So first, we normally have a homeostatic balance between our inhibitory and excitatory neurotransmitters, GABA and glutamate. And when individuals acutely drink alcohol, alcohol is a CNS depressant, so we have an increase in our inhibitory neurotransmitter GABA and a decrease in our excitatory neurotransmitter glutamate. So then what happens when individuals develop alcohol use disorder, our brain tries to compensate for this increase in GABA. And so what happens is our body tries to increase our excitatory neurotransmitters by upregulating glutamate to compensate to our inhibitory neurotransmission with GABA. So then when these individuals have alcohol withdrawal syndrome, this is characterized by cessation or abrupt decrease in the amount of alcohol that they typically consume. You take away the CNS depressant of alcohol, so you have an continued upregulation of glutamate, which is your excitatory neurotransmitter. And so you start to see some of the side effects of alcohol withdrawal syndrome, which I'll discuss on the next slide. So clinical presentation of alcohol withdrawal syndrome, this presentation is non-specific with the signs and symptoms, so it can be difficult to diagnose. It's very individualized, and not all patients will experience all symptoms. So typically within 6 to 24 hours, individuals will start to have anxiety, insomnia, tachycardia, diaphoresis, hypertension, hyperthermia. They can have some GI upset and present with anorexia. And then around 12 to 48 hours, this is when we start to see those hallucinations, our auditory, visual, and tactile hallucination. And this is when individuals are at highest risk for withdrawal seizures. Then around 48 to 96 hours, patients are at really high risk for delirium tremens, as well as more confusion, disorientation, and extreme agitation. So then when individuals present with alcohol withdrawal syndrome, it's important that we diagnose these patients and really try to assess what's going on. So when we're screening these patients, the most commonly used tool to screen individuals with alcohol withdrawal syndrome is the Clinical Institute Withdrawal Assessment for Alcohol scale, most commonly known as a CWAS scale. This is used to determine the severity of withdrawal symptoms as they're actively experienced. And this is a 10-point validation tool, which you can see to your left, which includes nausea or vomiting, paroxysmal sweats, anxiety, agitation, tremors, headache, auditory disturbances, visual disturbances, or tactile disturbances, as well as orientation and clouding of sensorium. And then depending on how these individuals score, that's how we can test the severity of their alcohol withdrawal. So the American Society of Addiction Medicine states that mild alcohol withdrawal is a CWAS less than 10. They state moderate is 10 to 18, and then severe or complicated alcohol withdrawal is greater than or equal to 19. So then looking at the acute management of alcohol withdrawal syndrome, Again, the American Society of Addiction Medicine recommends that benzodiazepines be our first-line treatment option for these individuals. As we know, benzodiazepines increase the frequency of chloride channel openings on GABA A receptors. And then our most common adverse reactions here are respiratory depression and hypotension. I've listed the most common medications that we use for individuals with acute alcohol withdrawal syndrome, which are lorazepam, midazolam, and diazepam. You can see the onset of action varies between the agents and duration. And really, lorazepam is our preferred in hepatic and renal dysfunction. Midazolam might require more frequent dosing due to its shorter half-life, especially when used IV. And then diazepam has a longer duration of action, so you could be concerned with some dose stacking if you're frequently dosing diazepam. So then the question becomes, what happens if your patient is responding to this first-line treatment option of benzodiazepine, is not responding to the first-line option of benzodiazepines? So that's where we get benzodiazepine refractory alcohol withdrawal. And this is really thought to occur due to downregulation of GABA and an increased activity of excitatory NMDA receptors. There's really no clear consensus on what qualifies as benzodiazepine refractory, but it's suggested that empiric benzodiazepine cutoffs are equivalent doses of 40 milligrams of diazepam in 1 hour or 200 milligrams of diazepam in 4 hours. And I have listed below here the equivalent benzodiazepine dosing. So around 8 milligrams of lorazepam in 1 hour is suggested as benzodiazepine refractory. So then we're looking at phenobarbital for refractory alcohol withdrawal. And then the American Society of Addiction Medicine here states that phenobarbital may be used in patients who remain in alcohol withdrawal after this benzodiazepine use. And so phenobarbital increases the duration of chloride channel opening, and enhances activity on GABA receptors, and it has antagonistic activity on NMDA receptors. The onset of action is around 5 minutes, but phenobarbital does have a long half-life of around 80 to 120 hours. Our most common adverse reactions with phenobarbital are, again, significant respiratory depression as well as hypotension. It's a strong inducer of CYP3A4, and it is hepatically metabolized. And then dosing can be fixed or weight-based. So then looking at some studies for phenobarbital for refractory alcohol withdrawal, the first study is by Rosenson and colleagues, and they looked at patients presenting to the ED with suspected alcohol withdrawal and the anticipated need for hospitalization. And so this was a prospective randomized double-blind placebo-controlled study that looked at phenobarbital 10 mg per kilo and 100 mL versus placebo. And then in this study, all patients received the CWA benzodiazepine protocol. And then looking at level of hospital admission from the emergency department, so individuals who received the phenobarbital versus placebo had less hospital admission from the ED, and then hospital length of stay was shorter in individuals who received phenobarbital versus that placebo. And then the total lorazepam required was a difference of 23 milligrams. So individuals who got phenobarbital only received about 26 milligrams of lorazepam, whereas the placebo group received 49. And then looking at this next study from Tidwell et al. In 2018, this study looked at patients being admitted to the medical ICU that were being treated for the onset or prevention of alcohol withdrawal. And this was a retrospective cohort study looking at benzodiazepines, which was their CWA protocol, or a phenobarbital protocol of around 140 to 240 milligrams per day. And this dosing really depended on if the patients were presenting with delirium tremens or not. And so here, they looked at ICU length of stay. So in the phenobarbital group, they showed a shorter ICU length of stay, which was statistically significant. And they showed a shorter hospital length of stay, so around 4.3 days with phenobarbital versus 6.9 days in the CWA group. And then invasive mechanical ventilation, only one patient in the phenobarbital group was mechanically ventilated versus 14 patients in the CWA protocol group. And all of these outcomes were statistically significant. So from these studies that we have, we can say that phenobarbital is beneficial in the treatment of alcohol withdrawal syndrome, but what remains in question are these dosing strategies, and this really is what remains unclear, and that brings me to the study that I'll be talking about today. So the study that I have for you all is front-loaded versus low-intermittent phenobarbital dosing for benzodiazepine-resistant severe alcohol withdrawal syndrome that was published in the Journal of Medical Toxicology earlier this year. So the purpose and clinical question, so it's understood that symptom-triggered alcohol withdrawal syndrome that's treated with phenobarbital has shown significant reduction in ICU admission, mechanical ventilation, and overall benzodiazepine use. But as I mentioned, uncertainty remains over phenobarbital dosing strategies, given its ability to cause severe respiratory depression. So the purpose of the study was to compare the need for mechanical ventilation in patients who received a front-loaded phenobarbital dosing strategy versus a low-intermittent. This was a single-center retrospective before and after study in a tertiary ICU setting, and they looked at all patients who were admitted to the medical ICU with the primary diagnosis of severe alcohol withdrawal, who also received at least one dose of phenobarbital from January 2013 to January of 2017. Their inclusion criteria was all adult patients admitted to the MICU receiving phenobarbital for severe alcohol withdrawal, and severe alcohol withdrawal syndrome was defined in the study as a CWAS score of greater than or equal to 20. They excluded patients who had a primary dose diagnosis other than alcohol withdrawal syndrome, any off-protocol dosing of phenobarbital, lack of safety monitoring, in which this study measured end-tidal CO2 in patients for at least 6 hours after they received the phenobarbital, and then any individual who was mechanically ventilated prior to receiving phenobarbital. So their primary outcome was looking at the incidence of mechanical ventilation. And then secondary outcomes included ICU length of stay, duration of mechanical ventilation, time to control alcohol withdrawal syndrome post-phenobarbital admission, which was defined by the authors as a CWAS less than 20, or if the individual was intubated, a RASS score of less than +2. And then lorazepam requirements in the 24 hours pre and post-phenobarbital administration, and then the need for any adjunctive sedative infusions. So looking at the intervention, so between January 2013 and July 2015, this institution used a low-intermittent phenobarbital dosing strategy where they used lorazepam 8 milligrams IV push every 15 minutes for 3 doses. And then individuals could receive phenobarbital 260 milligrams IV push times 1, followed by 130 milligrams IV pushed every 15 minutes as needed. This was capped at a total of 1,300 milligrams, so they could receive up to 8 of those 130 milligram doses. And then any additional therapies per clinician preference. And then in 2015, the institution switched to the front-loaded phenobarbital dosing strategy, in which they still did the same lorazepam 8 milligrams IV push every 15 minutes for 3 doses, but then they did phenobarbital 10 mg per kilo of actual body weight IV infusion over 30 minutes, again with those additional therapies per clinician preference. Their statistics for categorical data, they looked at a chi-squared or Fisher's exact test. Continuous data used students' t-test or Mann-Whitney test. And then for statistical significance, they had a 95% confidence interval with a two-tailed p-value of 0.05, which was considered statistically significant. For enrollment, so in their medical ICU, they had 187 patients with phenobarbital ordered. You can see the exclusion criteria there to the right, which most of the patients were excluded because they had a primary diagnosis other than alcohol withdrawal syndrome, lack of monitoring for complications, or some sort of off-protocol phenobarbital dosing. So in all, they had 87 patients who met the inclusion criteria, and it was pretty split between the two groups, and 41 patients in the low-intermittent phenobarbital dosing group, and then 46 patients in the front-loaded phenobarbital dosing group. For baseline characteristics, you can see the average age of the patients was similar between the groups of around, the median age was similar between the groups from 48 to 50. Males represented over 75% of their population studied, and the weight in kilograms, the median was similar, around 80 to 84 kilograms. You can see their past medical history there with prior seizures, other substance use disorder, or psychiatric illness was similar between the groups. And also baseline CWAS score prior to phenobarbital was 24, which was equal between the two groups, which I will mention, this was the baseline CWAS score prior to phenobarbital. So this means after the individuals received 8 milligrams of lorazepam for up to 3 doses, before they gave that phenobarbital, their CWAS score came back at a 24. What I think is worth noting to mention is the serum alcohol level and the time from last drink to admit. So as you can see from the chart I have here, individuals in the front-loaded group had a higher serum alcohol level than those in the low-intermittent group. This could probably be explained by the time from last drink to admit, as the individuals in the front-loaded group were admitted quite sooner than the individuals in the low-intermittent group at around 62 hours versus 81 hours. So then looking at results, So the primary outcome looked at the incidence of mechanical ventilation, and where 13 patients in the front-loaded group versus 26 patients in the low-intermittent group were mechanically ventilated, and this was statistically significant. And then looking at secondary outcomes of ICU length of stay, this was not statistically significant. Time from phenobarbital administration to control of alcohol withdrawal syndrome was also not statistically significant. And you can see here in the individuals in the front-loaded group had a longer time from time to phenobarbital administration to control of alcohol withdrawal syndrome. This could be because this was an IV infusion, which likely came from their central pharmacy or their IV room, which could take longer to compound and may explain why the time from the administration to the control of alcohol withdrawal syndrome was quite longer than those in the low intermittent group who was receiving push doses of phenobarbital. And then looking at the safety outcomes, so they looked at respiratory failure, which they defined as a need for mechanical ventilation, end-tidal CO2 greater than 50, or a pH less than 7.2. And as you can see, individuals in the front-loaded group or the low-intermittent group, there wasn't a high incidence of respiratory failure, but nonetheless, this was not statistically significant. And then they also looked at transient hypotension, which was defined as a systolic blood pressure less than 90. And so individuals in the front-loaded group had a lower overall effect of transient hypotension versus a low intermittent group from 22 to 56%. And this was statistically significant. This could possibly be described by individuals in the low intermittent group receiving push doses of phenobarbital, possibly causing that transient hypotension, whereas individuals in the front-loaded group received an infusion over 30 minutes. And then looking at phenobarbital and lorazepam utilization. So the cumulative phenobarbital doses between the front-loaded and low intermittent groups were actually similar, around 1,200 milligrams in both groups. And the mg per kilo also remains similar, around 15 milligrams. What I do think is notable is the lorazepam requirements. The median lorazepam requirements between pre and post phenobarbital in the front-loaded versus low intermittent. So as you can see from the chart I have here, individuals who receive front-loaded phenobarbital receive significantly less lorazepam than individuals in the low intermittent group. Looking at adjunctive sedative use, so the frequency of sedative infusions between the front-loaded and low intermittent group, there was a higher number of patients in low intermittent group that received sedative infusions. And then looking at the sedative infusions that were received, majority of patients received lorazepam. And then you will see that in the front-loaded group, there were more patients who received dexmedetomidine, so 20% in the dexmedetomidine group versus 4.9 in the low-intermittent group, which was statistically significant. So from the study, the authors concluded that front-loaded phenobarbital dosing, when compared to low-intermittent dosing for benzodiazepine-resistant alcohol withdrawal, was associated with a significantly lower incidence of mechanical ventilation and continuous sedative use. So some overall strengths, I think this is one of the first studies that compared front-loading to low-intermittent dosing of phenobarbital. I think it's very timely and important that we had the study. So this was a strength that I found. And the findings of this study are similar to other studies that assess phenobarbital and refractory alcohol withdrawal syndrome, especially reduced ICU length of stay or overall need for mechanical ventilation. And then the statistical analysis and clinical variables studied were appropriate. Some limitations that I found for the study, it was a relatively small sample size, but again, this was a single center study, so possibly to be expected. It was retrospective in nature, which could lead to selection bias. The severity of alcohol withdrawal was higher at baseline. This may limit generalizability as these patients were still scoring CWAS of greater than 20 after very high doses of lorazepam. And then additionally, baseline CWAS scores were not reported. So the CWAS scores that were reported were prior to the phenobarbital dosing, but we didn't have any CWAS scores that really indicated to us how these patients looked at true baseline upon being in the ED. So from the study, my conclusions were that in patients with severe benzodiazepine refractory alcohol withdrawal syndrome, front-loading phenobarbital represents a reasonable treatment option to limit ICU admissions. As we've seen from this study and then previous studies, this really could limit the amount of time that individuals stay or are admitted to the ICU with utilizing higher doses of phenobarbital. This study provided insight into the utilization of front-loading phenobarbital, but again, many questions remain unanswered. So around 43% of the patients in the front-loaded phenobarbital group were actually redosed with phenobarbital. But I had a lot of questions such as, how are these patients assessed to being redosed with phenobarbital? At what time point were they redosed with phenobarbital? And how, essentially, how did we assess these patients to when they should receive more phenobarbital? And essentially, both groups received the equal amounts of phenobarbital at the end of the study. In institutions where patients are seen with a lower severity of alcohol withdrawal, they might still be hesitant to use higher doses of phenobarbital up front. And this really could be because we don't have, providers are hesitant from a respiratory depression standpoint. And so this population had very severe alcohol withdrawal. And so it might be hard for our providers to possibly extrapolate this literature to patients who don't have such severe alcohol withdrawal. And then lastly, larger multi-center trials are needed to further define optimal dosing strategies for these patients. So as I mentioned, institutions who see patients with a lower CWAS score at baseline might want to have other trials which define an optimal dosing strategies in individuals with lower CWAS scores, so we can figure out what kind of front loading we can do for these patients in our institution. And with that, I'll take any questions that anyone has. Thank you.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.